you. So thanks everyone for signing in. I'm Colin Berry. I've been the cath lab director for the past year and a half here in St. John, and I'm going to give you an update on STEMI. And I think to give an update in STEMI, let me just start the slideshow here. Excuse me. I think to kind of give you an update in STEMI, it's worth revisiting how we got to this point in time and what new has happened. And there hasn't been a ton of changes in STEMI, to be honest with you, in the last period of time. However, there are some new topics and items that I think worth discussing. And again, I think it's important to review how we got to this point in STEMI, because it has been a kind of an evolution over the past probably 25 years in how we manage STEMI in our patients. So these are the overview objectives. So I'll kind of highlight our current guidelines for management of STEMI, and I again touch upon how things have evolved over time, including the pharmacology and our procedural techniques that we use during cardiac catheterization. And I think a few newer topics that are worth discussing are complete revascularization versus culprit vessel only. How late is it actually too late to perform intervention in cardiac catheterization in these patients? Touch upon dual antiplatelet therapy, because I think that's relevant for a lot of our STEMI patients, especially as we see older patients with multiple comorbid illnesses. And then maybe I'll touch on some future studies and some newer devices that may or may not have a role in how we manage our STEMI patients. So I think we know the pathophysiology well of the vast majority of STEMI. We have a small number of STEMIs that are due from embolic phenomenon, from either LV thrombus or endocarditis, but the vast majority is due to plaque rupture, and then the development of a completely occlusive thrombus in an artery. You get exposure of your subendothelial matrix, you get activation of platelets, and then you get thrombus formation, resulting in chest pain, ST elevation, and wall motion abnormalities. And these are the definitions we use to manage this, these reperfusion strategies, knowing what the pathophysiology is. We know if we want to reduce events, improve patient outcomes, we got to open up that vessel. And the old adage, time is muscle, is still as important as now as it ever has been. So we can either do primary PCI, that's immediately going to the cardiac cath lab and opening that vessel mechanically with ballooning and stenting. And then we have a pharmacoinvasive strategy, which is our predominant strategy throughout our province. And even in our center who has the cath lab, it's certainly probably a very common strategy used for many of our patients as well. Facilitated PCI is really not a strategy that we use anymore. It's had some interest previously, but it's not really a strategy anymore. It's worth looking back how we got here originally. This was the original study of aspirin as streptokinase done in the late 1980s, and you can see on the far right bar, the people who got streptokinase and aspirin had an absolute mortality reduction up to 5% compared with aspirin alone or streptokinase alone. So you can see this really changed management of STEMI at that time, and things have evolved just significantly over that time. We have better thrombolytic agents. This is a slide showing TPA, but now we have TNK, which is bolus administered, much easier to use. And we've had refinement of heparin dosing, and we've also had the addition of clopidogrel. So we've had a nice incremental improvement over time into adjunctive pharmacologic therapy to open that vessel. We've kind of gone from, sorry, this slide didn't completely translate, but from an era when we had just had bed rest for treating STEMIs, to the evolution of CCUs, to kind of now the 30-day mortality anywhere between 5 and 6% with good pharmacological management. So we've had steady improvements in mortality over time, and now we're just at kind of incremental improvements in mortality. The challenge with lysis is that we know that it's not as good as mechanically opening a vessel. When you compare the TIMI flow, which directly correlates with outcomes, if you can get TIMI 3 flow, which is normal flow, you get better outcomes. You can see with primary PCI, which is on the The bottom bar, you get better TIMI flow with intervention compared with thrombolysis, where you can only get about probably 65% TIMI3 flow. So primary PCI just results in better flow. And in patients who present early, that certainly results in better outcomes. This was a meta-analysis that really led to fairly widespread adoption of primary PCI. This was a meta-analysis of multiple relatively small trials and showed improvements in outcomes of mortality, recurrent ischemia, and other complications of infarct in patients who had primary PCI compared with thrombolysis. So back in the early 2000s, this led to fairly widespread adoption of primary PCI for reperfusion strategy in STEMIs in patients who you could deliver quickly. It is worth noting in this trial that only 3% of the patients who got thrombolysis underwent cardiac catheterization intervention. So in these trials, they really refused or didn't cath anyone. So it's really not the way we have practiced in a long time. So it's difficult to compare that to how we currently practice, but it was really only 3% of patients who got thrombolytic and even failed under a PCI at any point in time in these trials. So because of those, the limitations of thrombolysis and the fact that we weren't routinely incorporating cardiac catheterization and care of these patients, this led to a lot of studies looking at combining the two modalities, because we know that not every center has a cath lab. Not every center who even has a cath lab can staff it 24/7. There are logistic challenges in getting patients in quickly and opening that vessel within the 90 to 120 minutes that's recommended. So this led to multiple studies, and all these showed that if you routinely cath somebody post-STEMI after they've received thrombolysis, you get much better outcomes with routine early PCI. And you can reduce mortality to around 4%, which is really very similar to the results with primary PCI. So if you incorporate this strategy, you can get very good clinical outcomes similar to primary PCI. And this has been demonstrated in kind of multiple observational studies done in multiple regional centers throughout the country. So based on this fact, the 2019 STEMI guidelines were updated. They hadn't been updated in more than probably 15 years prior to this. And really was focused on regionalization of STEMI care, development of regional STEMI centers with a hub and spoke type model. And we started this here in our province in 2011, initially piloting with the Georges Dumont, and then to the Moncton Hospital, and then kind of expanding it throughout that year to the rest of the province. And I think it's worked reasonably well and for most STEMI patients. They get the diagnosis made. The emergency physician will contact us directly, tell us the clinical history, and we immediately accept that patient to the heart center for further management. And if all things goes well, we have a timely EMS transport, but we know that can be challenging at times. So again, this pharmacoinvasive strategy is a routine rapid transfer to PCI centers after thrombolysis. And if they've failed thrombolysis, we perform immediate PCI. So we now have a strategy of contacting the ambulance within 30 to 45 minutes of the arrival at the heart center. And if the patient is clinically unstable, ongoing chest discomfort or ongoing ECG changes, we will have the staff and the lab open for that patient by the time they arrive, so we can immediately perform their intervention. If they arrive and they're clinically stable and their ECG has normalized or near normalized, then we cath all of them within that 24-hour period of time. And this is the 2019 CCS kind of strategy flow chart. Again, if you have a primary PCI center, it's primary PCI. But again, if you at a non-PCI center, you make that decision about reperfusion and thrombolyze that patient if they have no contraindications, or if they're less than that 12-hour presentation time, and transfer immediately to a PCI center. These are our goals. I don't think we need to go through these in a lot of detail because they really haven't changed too much. Again, we want to make that diagnosis very quickly. We want to get the reperfusion strategy decided very quickly. Either you activate the cath lab or give them thrombolysis, and you want to make decisions to transfer in and out of that referring emergency as quick as you can. And pre-hospital diagnosis is ideal if people present through 911 or EMS, but not there's still a significant number of patients who do not present via EMS. Some of the technical things that have improved over time, and we know based on multiple studies that the way we do our intervention improves outcomes. So the radial approach has been shown in multiple different studies, certainly to reduce the risk of cardiac catheterization. Certainly less bleeding, appears to be less stroke, and even in some studies, less ischemic complications. So in the vast majority of patients who technically can have the procedure done radially, radial approach is preferred. And especially very useful for patients who've recently gotten thrombolysis in terms of bleeding, and patients who are overweight, elevated BMI, with technically access from the femoral approach can be challenging and have significant risks. So the radial approach is well documented, and that is the current standard of care. The choice of stent type, that has changed over time as well, and clearly pretty much no matter what patient subset you look at, if you pick STEMIs, non-STEMIs, vein grafts, people at high risk of bleeding, elderly patients, whatever, doesn't matter. DES is safer, better, less mortality, less restenosis compared with bare metal stents. The bare metal stents really are not devices that we use or I've used in a long time, because DES are better in virtually any way and safer, the current generation. So these are some of the procedure aspects. As you see in that middle bar of the dark balloon, we used to routinely use GP2B3 inhibitors. Now they're really used selectively in people who have a large thrombus burden. We don't give intracoronary lytics because the data really for that is quite poor. We may use them in very highly selected patients with a very large thrombus burden. But generally speaking, the data around them is weak, and it's based on small studies. We used to perform aspiration or in a significant number of patients with aspiration catheters, but that has fallen by the wayside as well, because that has not proven to be helpful. So we go radially, we use DESs, we use heparin as our primary anticoagulant strategy, and then we revascularize that culprit vessel. What is important, and I'll touch on next, is what we do after we fix that culprit vessel, or if they have multivessel coronary disease. If the lytic has worked and they have multivessel coronary disease and they're a good surgical candidate, we get cardiac surgery involved. If the thrombolysis hasn't worked, or the patient has ongoing symptoms or unstable, then we fix the culprit vessel. And if they have residual coronary disease, then we make a decision based on the patient's anatomy, clinical background, on the best way to revascularize them. So historically, we would not necessarily revascularize all vessels in the settings of STEMI. We'd often use an ischemia-driven decision-making process, where if someone came in with an inferior STEMI and we fixed a 90% stenosis on the right, but they had a 70% mid-LAD, we may not often routinely fix that patient. We would say do a stress echo, a stress nuclear study, follow up in 4 to 6 week time, and if there's ischemia, then we'll fix it. If there's not, then ongoing medical therapy is recommended. But that practice varied. Some people would come back and get fixed, some people would not, and it varied between centers and varied between physicians. So the complete trial was done published in 2019, and this was to address this exact question. So you randomize people to get revascularization of any stenosis above 70% after you fix that culprit vessel, or if it was 50 to 70 and it had an ischemic FFR. And they put them into 2 groups, complete revascularization or culprit only, and looked at the outcomes, follow up to 3 years. And as you can see in this slide, that we get cardiovascular death or reinfarction, or cardiovascular death, reinfarction, or repeat revascularization or ischemia-driven revascularization. The patients who had complete revascularization did better over time. And this was a significant number of reduced non-STEMIs, especially smaller number of STEMIs, and certainly less ischemic-driven revascularization as well, so less chance of having to come back to the cath lab. And the number needed to treat is a reasonable number, 37 and 13 respectively for the two. And this has been the approach that we've adopted now. It should be noted that the patients who get the ischemia or get repeat revascularization on the non-culprit vessel, it's not necessarily one of these CHIP or high-risk cases. They're straightforward or less complicated interventions. So patients with complex anatomy, high-risk interventions, they weren't necessarily included in this trial. And their revascularization can occur during their initial hospitalization, or generally the recommendation, the majority of these patients were done within 23 days, but it can be up to 30 days. So often we will bring people back in 4 weeks' time and stage their second intervention once they've got over their initial event. So either approach is reasonable, either in hospital or bring them back and stage as an outpatient. So this change has led to the change in the 2021 American guidelines, again, in patients who, after have had their intervention on their culprit vessel, a stage intervention on the non-infarct related vessel is recommended to reduce the risk of death or infarct. Just going to touch now on about how late is too late to intervene upon vessels in the setting of STEMI. Certainly the vast majority of the benefit we get within that first 4 hours. Once you get out to 12 to 24 hours, the data is certainly less impressive, but still there. And up to 48 hours, perhaps there's some benefit. And this is a large registry data from France of 3 separate STEMI registries with a lot of patients. And what they did is looked at patients who were late presenters, defined by 12 to 48 hours, who got revascularization, of patients who were late presenters who didn't get revascularization. And what they found was that if you got revascularized, even presenting late up to 48 hours, that there was some benefit, a significant benefit in terms of all-cause mortality if you revascularized patients. Again, this is observational data. It's not randomized data, but it does appear certainly that there's some mortality benefit in revascularizing patients, possibly up to 48 hours. So the European guidelines actually do recommend up to 48 hours, whereas the Canadian American guidelines have up to 24 hours. So I think there's some clinical decision making that needs to occur in these patients who present late. Certainly people come in after 24 hours, and if they don't have ischemic symptoms or ongoing clinical or ECG evidence of ischemia, I think the benefit is limited. But I think in patients who are not sure or have ongoing symptoms, I think we have quite a low threshold for performing immediate cardiac catheterization and intervening. So I think there's clinical decision making that has to be made in these patients. And people who we think have ongoing ischemia, based on how we clinically assess them, should undergo intervention and cardiac catheterization at least. Some of the newer things that have been researched, not just in STEMI, but in interventional cardiology, is how can we optimize the time of when we do our intervention on these patients to improve the outcomes, reduce the risk of stent thrombosis, do complex bifurcations or complex coronary disease with good results using adjunctive therapies. And I'll touch on those now. I did briefly mention the use of DES, and that's the kind of currently standard of care. Well, you certainly have adjunctive imaging modality, Optimize PCI, which is OCT, intravascular ultrasound. And the role of physiological assessment is less clear now, but hopefully will be more clear in the future. So we optimize them with our techniques, imaging technologies, and also I'll touch on DAPT post-intervention. So again, as I mentioned before, the choice of stent is DES for everybody, because again, it's improved all outcomes and all comers. We have these great adjunctive imaging modalities now with OCT, where you get really high quality images intravascularly. And this can really help us optimize our intervention. We can see the stent, how well it's expanded, if it's pushed against the vessel wall. We can see if it's sized appropriately. We can assess for dissections, distal and proximal to the stent, and deal with those at the same time. So the image quality is markedly improved with the use of OCT, and really gives us very detailed anatomy in patients and helps guide therapy. Whether or not this changes outcomes in STEMI, that will hopefully be answered, but probably certainly technically helps our intervention. Intravascular ultrasound has been around for more than 30 years, and IVUS guided PCI for the majority of studies have showed improved outcomes if you use IVUS. Certainly, especially for left main disease or complex cornea interventions, if you use IVUS guidance, it will help the technical aspects of your intervention and reduce outcomes. So the use of imaging for current management of interventions is less strong 2A, but certainly patients with complex anatomy, certainly intervention in left main disease, it should be the standard of care in patients, again, to guide our intervention and optimize our intervention. OCT has less data because it's a newer technology, but I think with time, its role and recommendations become stronger with time. I want to touch on dual antiplatelet therapy now because it's not just for STEMI patients, but for all of our ECS patients. It's been the standard of care. And you know, when probably 10 or 15 years ago, we were discussing about dual antiplatelet therapy forever. And some centers were doing that regardless for any patient. But the data for that really was not great. And the DAPT trial, which was a huge trial looking at this question, showed you could reduce ischemic outcomes, but unfortunately it came at the price of a lot more bleeding, complications, despite a relatively low risk population of patients around the age of 60, and worrisome led to an increase in trend toward increased overall mortality. So you're treating everyone with prolonged dual antiplatelet therapy for over 12 months, but you really, although you might prevent a small nerve infarct, you were actually causing a lot of bleeding complications. And again, worrisome was a trend for increased mortality. So the duration of DAPT has really swung the other way now. We recognize these bleeding complications are very important, especially in elderly patients with significant comorbid illnesses, and we really want to reduce that. So this is just one study out of multiple studies that look at abbreviation of dual antiplatelet therapy. This was one looking at ticagrelor and aspirin for 3 months after their intervention, and after 3 months, they would either go on ticagrelor monotherapy or ticagrelor and aspirin for 12 months. And clearly, what this study has shown, along with several other studies, that with monotherapy with ticagrelor alone, you get much less bleeding complications with really no excess ischemic risk. So that theoretical benefit of prolonging dual antiplatelet therapy over time really hasn't persisted past the 3-month period. And in some studies, it's even up to after 1 month. You really get the benefit of reducing ischemic complications, but none of the bleeding risk. And we know bleeding in these sick patients, elderly patients with comorbid illnesses can be very difficult to manage, especially if they've had a recent infarct. The majority of these studies have looked at ticagrelor after a 1 or 2 month period of dual antiplatelet therapy, but clopidogrel has been looked at as well. And again, it's felt that the benefit probably of adding aspirin to a potent dual antiplatelet agent is less so. So I think this is going to be something that we see more use of more in the future, and our guidelines currently have reflected that. There's a bit of a complicated slide. But basically what it says in ACS, which is on the bar on the right, still the recommendation is up to 12 months, but certainly patients are high bleeding risk. Abbreviation after 1 to 3 months is appropriate, but you must transition to not to aspirin, but to monotherapy with a P2Y12 inhibitor, either clopidogrel or ticagrelor, which has the best data. For stable coronary disease, we've transitioned most of us to 6 months of dual antiplatelet therapy post PCI. So we've kind of come to this less is more now. We find that the vast majority of the ischemic benefits up front, and prolonged dual antiplatelet therapy really does not seem to be a benefit and has significant risk. So the current recommendations, again, these are the 2021 recommendations, of 1 to 3 months is reasonable. With transition to a P2Y12 inhibitor monotherapy. And again, largely driven by a reduction in bleeding events with no risk of future ischemic events. What do we have coming in the future going forward as adjunctive therapies for STEMI? Aspiration, I touched on that earlier. We have these great devices that can aspirate thrombus out of vessel, but the routine use really did not result in any good outcomes and unfortunately led to more stroke. So that's been really relegated now to use only in really highly selective patients with large thrombus burdens and ongoing symptoms. But the devices that we have now currently are basically a syringe attached to a long, thin tube in manual aspiration, but there's mechanical aspiration devices now that have been used in the interventional radiology world. And perhaps these will become more prominent or used more commonly in the interventional world. This was a study just looking at the technical success of the device, and the device proved to be very safe with no excess risk. It's not a randomized trial. It was just used in patients with high thrombus burden, and whether or not you could use it technically, appropriately, and safely, and certainly was proved to be safe. The next step is a large study looking at this in ACS patients. That has been announced late last year and will be performed whether or not people with large thrombus burdens that are clearly defined angiographically will benefit from routine mechanical aspiration. And the benefit of this device is you have a consistent suction strength during aspiration. And again, it's been proven useful in the interventional radiology world, and hopefully it will help in the interventional cardiology world as well. Another study that hopefully will give us a bit more guidance in STEMI and non-STEMI patients is whether or not physiology will help and OCT will help manage our patients in STEMIs. So there's a substudy of this looking at OCT in non-culprit vessels as well. So hopefully with time, whereas physiology guided PCI in stable coronary disease has been very useful, and in unstable coronary disease or non-STEMI and STEMIs, the results of studies have been variable and have not been as helpful. So hopefully this will help clarify the role of physiology in acute coronary syndromes, and also help us give us more guidance on the utility of OCT, looking at non-culprit vessels. So I'm going to stop there. There's a few newer technologies that hopefully will come with time. Our DESs are always evolving, and the improvements now are fairly incremental and small, but they are getting safer. But I think over time, for interventions, we'll have newer stents with less stuff on them that are safer and will allow us to use shorter periods of time for DAPT. And we'll increase our use of imaging and physiology to guide what we do in patients, and not just fix necessarily everything that we see, but things that are actually physiologically and clinically important. But I think that's useful to mention at the end, the heart team is at the core of kind of all we do. So although the acute STEMI, often it's the cardiologists, the interventional cardiologists deciding together what to do for the patient. Many of these patients have multi-vessel disease, and heart team discussions are kind of at the center of care of patients. And we often involve our surgical colleagues, especially for patients who have STEMIs and come and get successful lysis, will go on to have cath and have multi-vessel coronaries, because we feel that surgery in a lot of these patients is the best revascularization modality long term. So the heart team has always been at the core of our decisions, and it helps guide our therapy and improve our patient outcomes. So I'm going to stop right there. Thank you guys for attending. I've just gone a little bit over time, but if you have any questions, I'd be happy to entertain them. If anyone wants to go ahead. Thank you for your time.
Okay, do we have questions? Not too many. Dr. Barry, thank you for an excellent presentation.
Thank you.
I have a quick question, if I'm allowed. So in terms of our local STEMI program, can you comment on our kind of success time in terms of activation? How many patients meet this criteria and how many don't?
Criteria for what? Sorry.
For activation time. Time to balloon, time to...
Yeah, unfortunately, that's been a challenge for us to obtain. We've had the approach which has been the Alberta database for some time. And we had hoped that adopting that database would give us the information we need to look at door to balloon, door to time, and unfortunately has not. And now the database is probably the best recognized Canadian database, but the software for that database has been sold to a private company. So I know Dr. Legary and others have been trying to look into this as best we can, but we have not had success in getting the data. And I think that's one of our challenges or shortcomings. We want data, but our current databases is not enabling it. So I think it's something, it's a good point and well brought up, and it's something we really need to improve if we're going to try to identify where our shortfalls may be and improve on them. Because I know there are shortfalls, I'm sure. Time to diagnosis, transfer times, opening a door to balloon times are all things we can get better. But unfortunately, we don't have good data for that right now.
Thank you. And I think Dr. Sharif has a question.
Oh, hi, Colin. Thank you very
Hi,
much for that. I was just a question with regards to the complete trial. I remember way back when, like before that study came out, there were some people who would say some of those non-culprit lesions actually didn't look angiographically significant when they went back in the second time, and that was why there was some debate of what to do. In your experience, since you guys have been kind of doing more of the staged PCI approach for those non-culprit lesions, do you find that there are some where you go in and you're like, yeah, that's not bad enough, we're not going to do anything? Or do you find that the majority you're actually intervening on?
I think because we're intervening earlier now, that more than they look fairly similar. So I'd say that we are, because we're being relatively more aggressive, doing the intervention during the initial hospital stay or shortly after discharge. They're not looking that different. They come back a short period of time. I certainly will say I saw a patient, and we do, all of us see this. I saw a patient who had a STEMI back in 2021, severe multivessel disease, and he was offered surgery at that time after having his culprit fixed. And he didn't want to have surgery, didn't want to have any further intervention, just wanted to go home, and he did well, but came back again. And his LED and circumflex do not look that bad anymore. They look much better. And I just fixed the distal right in them. So I think we probably don't give it enough time anymore for our medical therapy to work for these STEMI patients. We kind of want to get them all fixed quickly. But I do think you're correct in that we do see patients who come back, who've had intervention back, probably longer than a month ago, but a year or more ago, and we come back and recath them, and their anatomy actually looks angiographically better compared with their initial event. And this was just one recent example I had, but I think we all have multiple examples of exactly what you said.
Okay, thank you for your question. I think we ran out of time. Dr. Barry, thank you again for excellent talk. And I'll see everyone next week.
Great, thank you.
Thank you.